The recording has started. Okay. So Lauren's going to record this. So I'm Mary Lynn. There's a couple of you guys that I don't think I have met before, so I'm assuming you guys are from ICU. Okay. What's your name? Oh, Nikki Anna. I know all about you. I work. Liz and I go way back. So, yeah. And Kimber, and yeah, we go way back. So, and you're Nikki. Okay. Nice to meet you. And Celeste. Okay. So I'm Mary Lynn Hippie. I'm the clinical nurse specialist for Tele. And so we are going to talk about the care of the cath lab patients since we're starting to get more cath labs and we're starting to get interventions. I just wanted to kind of get everybody sort of level set and try to get us all on the same page. So kind of starting fresh since it's been so long since we originally had, you know, kind of training and people oriented and stuff. So Lauren's recording it, as I said. That's why I'm wearing this funny headset. And so I'm kind of stuck up here at the top. And then I'm going to ask you guys, if you have questions, I'm going to have you write them down. And let's get through the presentation and then go back to questions. Because I think if you have questions, they may come up, answers may come up later on. And then we'll just kind of go from there. Okay? All right. And then I have Rachel on the phone. All right. So this presentation I kind of took from a presentation that we do for new grads. And I sort of adapted it. So I tried to pull out some of the stuff that you already know, but there's just kind of some basic things, so I might just run through a few slides that are just kind of refresher stuff. And so talking about what they do in the cath lab, that's a pretty... Rachel, are you able to see the screen or no?
No, I am not. I'm
okay.
Sorry.
Okay, no, that's okay. I'll just try to keep that in mind as I'm talking, just to give you a little bit more detail, because I don't usually read slides to people, but I'll just try to... give you a little more to hang on just a second. We're not calling in on the phone. Oh, you're wanting something. Okay. Sorry. Someone was at the door pointing. Okay. All right. So just starting out with this, I think this is an important thing to cover where we talk about left heart cath versus right heart cath, because I know that this is an area that I have seen struggle with nurses. And so just on the left heart cath, what they're looking for on that, they can get a better accuracy of ejection fraction than you can get over just doing a normal echo. You do the coronary angiography, so using contrast to actually visualize what's going on in the vessels, and then of course to do an intervention. This bottom one here about the access, I think is the really important thing I like to point out, because sometimes I hear when they say right heart cath or they say left heart cath, the nurses think that's the side that they're going in on their groin or on their arm, and so I like to make it really clear. So if they're doing a left heart cath, you know it's going to be an arterial because they're coming up the artery and they're dropping down into the left side of the heart. And so it's either going to be a radial approach, which 90% of ours now are radial approaches, and then if for some reason there's something anatomy-wise or they have a difficult time, then we're seeing the ones that are going in femoral. And then on the right heart cath, we don't see as many of those, but they're usually for diagnostics of pulmonary hypertension. It's actually the only way you can 100% diagnose someone with pulmonary hypertension. Review of tricuspid valve disease, which isn't very common. And then that is always going to be a venous, and that's going to be either your right or left, depending on what anatomy is like, but that's always a venous stick. And then sometimes we'll see them do both the right and the left at the same time, which means you're going to have a venous and an arterial stick. And then this is just some pictures showing you the radial femoral. All right. So going through the order sets to start, just so you know what's in there. When the doctors get ready to order these procedures, they have 3 order sets that are in there. One is the pre-procedure, and then they have a post-cath lab for intervention and no intervention. There's not a big difference between those two, but there is a little bit of a difference. So those are the order sets that they're using. I want to go in, and I should have logged on before. I wanted to go into PPE because I really want to walk through some of this stuff and really show you guys what these orders look like online. Because I think if we start, I can't see. If we start from really looking at the order sets, can't type and talk at the same time. I think that just sort of helps visualize a little bit better. I did some screenshots in here, but I also, like I said, I think it's just better to go in. So I'm in PPE, and you guys are probably familiar with PPE, you guys can go into this and play at any time. So if you're ever wanting to look at something on an order, you can just go in and play away orders, do it whatever you want, and you're not going to hurt anything. It's just a copy of live that happens once a month. They go in and copy it over, and then you can see just scramble information. So this is what the orders look like on the physician side. Now they can go in and they can do some modifications and do some favorites for them, but I wanted to kind of show you sort of what the raw order looks like so you know what kind of things are already pre-checked. And as we're talking through this, if you guys think of things that you're seeing with the orders that don't seem right, they're missing, or why is that there, write it down, because I've been working with the physicians on trying to clean up some of the orders too. So all right, so I'm not going to spend a ton of time here, but you've got your nitro, you've got your vitals. This is all the pre-stuff, so there's not a ton in here. Your NPO. Then you've got your intervention. So you can see they have all of this stuff already pre-checked. Hold Lovenox, hold heparin if the patient's going to cath lab, hold metformin, the pre-procedure for the RN to assess and mark the distal pulses, and then the void on call. So what they should be doing is if it doesn't apply to their patient, if the patient's not on heparin, they should be unchecking that. But just so you know, if you ever see it come across, you're like, why is that on there? It may be that they just forgot to uncheck it. And then you have your skin prep on here that gives you your prep and shave of the right groin to the midline, and then the radial. And even though 90% are radial, if they have that time when they just can't get in, they have to go. The patients are draped sterilely, and they have this site ready and this site ready. So as soon as they can't get in here, they can just jump right to their groin site. And so that's why we continue to prep both sites, even though 90% of the time they don't use it. Here are all the consents on there. There's a lot of labs. Most of these labs that are ordered are usually for outpatient procedures, so we don't see a lot of labs get pulled through on the inpatient ones. You have your IV fluids, and then your aspirin. Now, one of the questions that comes up a lot is the aspirin. A lot of times the patient comes in and they're already on 81 milligrams, and they had the 81 like at 9 o'clock at night. Now it's the next morning and they need the 325. I'm working with the physicians to try to get a standard on that, but for now, if you see that, we just need to call them and clarify what they want. I told them, I said, they're like, oh, just call us. And I'm like, no, not just call you, because that's a lot of work for us to do. So let's get this figured out, because some physicians are okay with the 81, some want the 325. So anyway, so that is an area I'm working on with them. And then you have your pre-procedure meds down here, and you might have Benadryl, Valium, one or both of those. Okay, so I'm going to flip back out of that. Okay, so once the physician places the orders, your orders go in, and they're sitting over there because they're sitting in a phase of care. This is a really challenging piece because like all of our pre-op orders that sit in phase of care, some of the pre-op we have to do right away, some of it we do right the next morning, and some of it they actually do in pre-op. And so what I did was I tried to just pull a guide, and I think this is just something you guys will have to keep referring to until you really understand it and just kind of memorize it, on what should I release now and what should I release later. Because so the green boxes around here, oh, I kind of have one extra. It looks like I have an extra. Go back. Extra green box here. So this big green box and this big green box and this box is what should be released as soon as they write the orders, okay? Couple things to check. On the NPO, just make sure that it's an NPO after midnight, because they do have to go in and click that box, and when they're doing them for outpatient, they just leave it alone. So sometimes they forget. So just be careful that your NPO truly is set for after midnight so you don't stop their diet as soon as you release the orders. And then I'm going to skip these for a second. Then you have, because here's all those hold orders. We want to make sure, usually that Lovenox is due at 2100. So if you don't get those orders released when they write them at 5 o'clock in the evening, somebody's going to give that Lovenox, and then the patient's not going to be able to go to cath lab. And that's a really easy one to happen. I see you guys shaking your head. So you want to release all those. And again, they're not going to probably have all of these on, but this is what is on there. And then I made a note on your IV fluids. That's another one to kind of watch too. They usually want them started in the morning, but sometimes they say after midnight. So you want to look at that because, again, if they don't go in and change it, it will tell you to start those as soon as you release them. And that's not usually the case with any of the cath lab patients. It's usually going to be midnight. And if you look at it and it has you starting it now, that's probably a call to the physician because that's pretty atypical unless you know there's something going on with the patient that they would really want that started early. And then, of course, you have your consent, your vital signs. So what are you not releasing? Really what you're not releasing is your on-call meds. So you've got your on-call to cath lab meds. And then, like I said, kind of your sodium in there, or your normal saline, depending on when that is. What happens when you release these is as soon as you release them, they go on the MAR, and they sort of time themselves and sit there. And that's an epic thing. We know it's a problem. We'd love to be able to fix it, but unfortunately there's not a fix now. So we just have to really be aware. If you release this on-call med, it's just going to show up on your MAR. And we've had a couple of them given when they shouldn't be given. So this is kind of the guide to that. And Lauren, this is something we'll put in the book that I was kind of working on to give some guidance on that. Okay. All right. So then the next step is to pull the cath lab checklist. As soon as you see those orders, you get them released. Pull your cath lab checklist. I have an updated one. I think Lauren has an updated one that you guys all have. I don't have that one published yet. It's not much different other than it added NAMPA to it and took a bunch of things off the top of it. So get started on the checklist. So A and B is what needs to be completed by us. Whoever gets those orders should start on this. This isn't a wait till nighttime. It wasn't not wait till the next morning. It's a fluid process that whoever gets it just sort of starts working through the checklist and getting things completed as they can, okay? And on the checklist, it gives you the stop bang screening, so making sure you're getting in. You guys are probably all aware that there's that pre-op section that is in MSL. We don't use that for cath lab patients, and there was just a change and a new thing that came out with that. We're not using that for our cath lab patients at all, but that is where your stop bang screening is. So you can get in there and do your stop bang screening, but you do not need to do that pre-op checklist for cath lab patients, okay? This is the checklist you need to do. So, and then this section we'll get to. This is section E. I kind of blew it up. It's in the bottom right. And this is the section that's for post-cath lab that the cath lab is supposed to complete before they bring the patient back to you. Okay? All right. So, patient comes back from cath lab. So this section E should be filled out by cath lab. If it is not filled out by cath lab, you need to ask them to complete it. This is their report to us. And what we don't want to have to do is go in through the chart and try to find all of these things. They're sitting there, and when they're completing cath lab, this checklist is right there with the person that's doing their documentation, and they can very easily just go through and mark all of these things. That way you have everything you need in one place, okay? We are working on a plan to hopefully get this pulled into a report. COU is using this in Boise, and I would love us to be able to use it, but we're trying to figure out if they have to kind of build it for us because it's in Cupid. It's not in ClinDoc. So, but anyways, for now, this is what they should fill out when they come back to you. As soon as the patient gets back into the room, you need to make sure you get them attached to the monitor. So for tele, if they're on tele, we have to put on the tele box and the bedside monitor, as you guys know. And so we're still working on that. Space Labs has a fix, but it's going to be a while because everything's a while for Space Labs. So hopefully by January we'll have it where we can actually just hook them to the tele box and remote view them. And then for ICU, you guys are probably just hooking them up to your bedside monitor, so you don't have to worry about that. And then as report with the cath lab staff, you guys should be reviewing this section together. Additional things that just to kind of ask, it's kind of in here, but are there any complications with access? We want to know because sometimes maybe they go radial, they couldn't get in. That's usually pretty obvious. And then maybe they've done 2 sticks in the groin. We need to know that. And if we don't ask, sometimes that gets missed. And that can be a pretty significant problem if the patient starts to bleed and you didn't know there were 2 sticks there because you don't know which stick they're bleeding from. So, and then verify Plavix was given. That's up here on the list, but it's always a good one to really pay attention to. We do pretty good with this, but in the past, we've had a couple of misses where Plavix wasn't given to the patient. We thought it was given in cath lab, and we didn't give it. So it's just a good one to kind of pay extra attention to. Review any IV infusions that the patient's on. They may come back on saline, but we do have some patients that are coming back like on integralin and stuff, and we can take those drips just fine. But just make sure you know if there's any drips coming back, that you know where they're at in that, because integralin is usually like a 6-hour drip, and there's some settings in there you need to know about. So together, look at the growing of the radial site and check the pulses together in the room. And then review that first set of vitals and rhythm. So these are things that we want the cath lab staff in the room, and they know this, in the room checking and looking at with you. Okay, so make sure you kind of get all this done before they scoot on out of there. And then I know for them, it is a frustration for them when they show up and then they stand in the room for 5 minutes and no one comes, and we work back and forth with that. Hopefully they call ahead of time so we know they're coming, because they should be calling you and saying, hey, we're bringing the patient back. That gives you time to get prepared. But just be aware, if you know that they're coming back, try to get into that room as quickly as you can, because they do have to get back to cath lab, especially if they do have another case. And as they get busier over there, you know, the other sites are just, you know, they flip their cath lab pretty quickly. They have like a 20-minute between ending one patient and starting another patient, and there's 3 of them. And so they have to get back and help prep those rooms. So, okay, and then making sure that cardiologist connected with the family so that the family's not sitting out in a waiting room somewhere and don't know that the patient's back. All right. So, review the orders really carefully, and we'll pull those up, the post orders up here in a second. The other thing is the ST monitoring. You want to make sure that you have your ST monitoring and your alarms are turned on, because we typically don't have ST alarms on other than for specific patients, which is very few of ours. So you want to make sure the alarms are on and that your leads are set for the appropriate based on where the intervention was. And the next slide shows that. The tele clerks have that. Did you ever get that badge card?
I don't think so.
I don't think you did. We'll follow up on that. There's a little badge card that we have too, and so we'll follow up and see if we can get that badge card.
It's on the wall, so.
It's on the wall at the tele clerk. But really, the nurse should be telling the tele clerk, if it's for tele, telling them what leads they want. Okay, they shouldn't call and say, you know, they just had a stent placed in their LDA. They have a stent in their LDA. How about LCA? And expecting them to know what lead it is. So. Okay, and then just monitoring those leads. Our policy is plus or minus 2 millimeters from baseline. We should be contacting provider. Obviously, first check the patient and are my leads in the right place and all that stuff. But vital signs and assessments are Q15 times 4, Q30 times 2, Q1 hour times 4, and then per your patient care guidelines. So for these patients, when they're coming to ICU, you guys are just following tele guidelines on them, right? As far as after their recovery, if they're tele patients, okay, which most of them should be, unless they're a STEMI or something. So, and then your assessment is the continuous pulse ox on the same side as the radial TR band, either on their thumb or their forefinger. Puncture site check, so looking through that, you can't see it really well through the TR band, but looking through that TR band, checking their color, temperature, and their distal, and then restricting arm movement. And these patients usually have bathroom privileges to get up, okay? And then if it's a femoral, then it's your puncture site, your pedal pulses. They have to be flat, at least for the first hour. And their bed rest is usually 4 to 6 hours. The RN has to do the site checks and the assessments. And so, honestly, your CAP's not a big help here. If you got things every 15 minutes, you have to be in there anyway. So just be aware of that and work that out with your CAP, because maybe they can follow up with some of your other patients and do some of your other things while you are on those, especially those frequent ones. So I'm going to click here and I'm going to go back in, and hopefully it didn't kick me out yet. It didn't. Okay. And let's just look at the post orders. You really have to read through these carefully, and after you do it a few times, you'll get it. But I think it's important just to make sure you're really reading through them carefully. And so you've got your cardiac monitoring on here. And then your vital signs, these are just kind of your routine. And then your diet should be in there. Kind of your general, just I's and O's, and notify parameters. You do have the ability to straight cath a patient. So if you have a patient that is not able to void, that is in these orders. So you are able to do that. And then, of course, if the patient has a hematoma, change in vital signs, chest pain, notify the provider. Scroll here. Not real important. There's your straight cath and nicotine cessation. If the patient, they should have that checked. I keep kind of scrolling here. I want to scroll down and get down here. I'm going to scroll. Here's your, if they have hypotension, you've got just your basic. You can give them fluid. Not going to help you a whole ton of a lot at that point. You do have atropine. Usually you're not going to need this unless you have a patient that ends up with a bleed or something and you're having to push on their growing and they may vagal on you, but you do have those orders to treat if you need to. So we have our interventions here. I'm going to go to the radial first just because the majority of what we're seeing is radial. So let me scroll here. And so here's your vital signs. They tell you right here, every 15 times 4, 30 times 2, hour times 4. Here is your color and temperature check. And so this is your distal compression band. So every 5 minutes times 3, then with your vital signs. So when they initially get there, you're checking it a little bit more frequently. And then there's your pulse ox. Then here is your release for your TR band, telling you how frequently you should be releasing air from it and the instructions. There's your bed rest with bathroom privileges, weight restriction for the arm, and then notifying the provider if you need to keep that band on longer than you would normally do. So that's mainly. Sorry, my throat's getting dry, Lauren. I think we talk too much. I know. Okay, so let me unclick that one, and let me click on the femoral site just so you can see that one too. So you can see when the doctor goes in on this, it actually pops up. They don't have a standard bed rest hours. The doctors actually have to put this in every time unless they have saved it in their favorites. But this, they may, depending on how much heparin they gave the patient, what was going on in cath lab, they may decide they want them laying longer. But typically they're going to use 4 hours. So they have to actually fill that in. It won't let them go past that unless they fill it in. So this is all for pre-sheath removal. We aren't removing any arterial sheaths anymore. So if a patient does come back with an arterial sheath, the cath lab staff is the one that's doing that. And so you'll make that decision with them, talk to them about it. Very few are doing that, but sometimes every once in a while they have one that has to come back with an arterial sheath, and our cath lab staff is the only ones that we are allowing to do that because it's such a rare thing that we're doing now and the risk is so high on it. And so but if they did come back with a sheath, we would still have to do the ACTs and all that prior to the pool. And then here again, here's all your vital signs. Here's if you have a hematoma or bleeding develops, apply your pressure, notify the physician. We actually have in our policy, if we have a patient that has a rebleed, the physician is supposed to come back in and see the patient. So obviously do what you need to do to stop the bleeding, but then we need to notify them. There's your bed rest. Here's if the patient vagals. Again, you have that atropine, and that's only going to happen again, like I said, if you have a rebleed and you have to hold pressure. Your normal saline. We also have lidoepi. If your patient, if they just have that ooze that just won't, kind of quit, then you can do a lidoepi on the patient. Okay. Then the rest of this is pretty standard. It's your oxygen, VTE stuff, and then meds. Okay. All right. There's the lead selection. That's on the policy. The teleclerks have it. It's in critical care policies. It's all the same. So, Okay, well, it's not that. All of there. So post-procedure for removing the TR band. So the orders say to remove 4 mils of air after the patient's been back for an hour, and then 4 mils every 30 minutes. This is a guideline. It's an order, but it's a guideline, okay? So if you're starting to release, you should be watching, and if you start to see it's going to ooze, just, put that air right back in it and try again in 30 minutes, okay? But this is kind of giving you that guide of how you should be doing it. And like I said, if you end up running into trouble and you're like trying to take it out, it bleeds, you put back in, and if you find yourself having to go back and forth on that several times, we need to notify the provider on it. So once you actually do get to the point where you've been able to remove the air, we only want that band left on for 30 minutes, okay? That's really important because we've had some situations where the bands have been left on longer and it's actually caused some clots for patients. And so 30 minutes, you got hemostasis, you should be good to go. Get that TR band off of the patient. If you can't get it off of them, because again, you're not getting hemostasis, to call the provider, okay? Yeah.
Is it bad to go down from 4 to like only 3 to 2 if that's what the patient permits you to?
Yeah, like you can only get 3 out. Yeah. Yep. Right, that's why I said 4 is kind of a guideline. If you find it, you're getting to 4, it's too much, but you go to 3 and it seems to be, I can hold there, let's just hold there. Yeah. Yeah, that's why I said it's kind of a guide. All right, so documentation. This is probably the piece I want to make sure the most that everybody's on the same page on, because it is a little confusing the way we have it in Epic, okay? So sheaths and TR bands should be inserted under the LDAs, and those should be done by Cath Lab because they're the ones that are putting them in. And then whoever's taking them out, which for the most part the sheaths are probably going to be removed in Cath Lab, so then that sheath LDA should be removed, okay? This is a big view, and then I'm going to cut down into it. So here's kind of shows you the LDAs. So this is a screenshot that I pulled out. You have your sheath, the next line down, section down is your TR band, the next section down is your vascular, so you can grab your pulses. So it does kind of flow nicely here, but I feel like it's also a little bit choppy. So when you get a patient back, if they've already removed this sheath, sometimes people have a hard time finding it. So here's a clue. Up here at the top of your flow sheet rows, there's a hide completed. If you have that checked, this sheath is not going to show for you. So if you're like, I can't find where that's at, it's probably because you have this box checked. So uncheck this box because this is where you're going to actually do your charting of your site assessment, okay? So documentation, after removal of the sheath and the TR band, it still continues under this LDA even though they've been removed because that's where your site is at, okay? Does that make sense to you guys? Like I said, this is probably the part that I just want to make sure. So hide complete, there's your little thing. So on this one you can see I removed it, so it's removed, but I can see it, and this is where I'm still going to do my site assessment. My line status is it's been removed already. If there's a dressing on it, you may not have a dressing yet because you have your TR band, okay? Here's your color movement sensation. And then if you have any complications, and then if you had to do any additional interventions, okay? And then here's your TR band. And when they come back, you have your mils removed. So every time you remove some mils, you remove it. If you have to put more back in, you can put it up here in this band inflated. So let's say you remove 4 and then you end up having to put 4 back in, 15 minutes later or whatever, put it back into that section right there. That's what I said. I think it's still a little messy and a little choppy. So I see your face. Is this the yes or no section? You're right. So the reason I'm saying that is because there's supposed to be a spot in here if you put air back in. Is it not in there? Okay. Write that down. Well, they were supposed to have that row. That's why I said that. And I was thinking to myself, that doesn't sound right, but it must be. But you're right. So that is actually supposed to be in there. And so make note of that for me. I actually have a meeting tomorrow to talk a little bit about this. So I will ask them because that was a long time ago that was supposed to be in there. Yeah, while you're on it, yes. Uh-huh. You kind of know what's in there. Well, yeah. It was, but that is the way it was supposed to be. That's why I was like a little confused when I looked at that, because this was like 6 months ago that this was supposed to be done. And so that's why when I started I don't get in here and document you guys. I'm just going to admit it right there. But I'm like, wait a minute. I thought we fixed that. So, all right. Noted. All right. So for now, do a comment. Thank you for that look on your face, because I'm like, something's telling me not right here. All right. Let me go back. Okay. So I think that's everything on that. And then this is just some of the kind of basic stuff. Radial versus femoral. We really went to radials. We saw a huge decrease in complications. And we're going to go through all the complications. But you'll see there's just so much less of a risk with these. Decreased bleeding. Patient satisfaction, obviously, that's a huge one, because laying flat on your back for 4 to 6 hours, nobody likes that. And then post-procedure cares. A lot better, easier too. So, but we do have some complications that can happen with radial site. And so this is probably the main one that I see, the top, that it's on too long, too tight. Too tight. We've had some problems with that. And so if you have a patient that comes back and they're like, my hand's numb, my hand's tingly, call the cath lab and have them come look at that and readjust it. We shouldn't readjust them, okay? If they're not on right, the cath lab staff is the one that's trained to put them on and center them and get them over, because, you know, there's the little pillow in there that's what puts pressure. And so they have to make sure that that's lined up just right. And so if you have a patient that's complaining, and it's funny because Jennifer Amadon just came in and left, and she's had a couple patients in Meridian that the patient came back and their hand, they're like, gosh, my hand is just tingling and it's numb and it's just okay. Rachel, can you hear us?
Yes, I can hear you now.
Oh, good.
Thank
That was
you.
Lauren. That was all Lauren's fault. I just want you to know that was not me. I'm glad you texted, because I'm like, am I still? She goes, oh, yeah, still good. Okay. All right. So, all right. So now we're talking about the complications for femoral access. So this is just a list of them. We have the bleeding, hematoma, vagal reaction, chest pain, which could be an abrupt closing of the artery. Usually if it closes, their chest pain's severe, like, you know, something's not right. You may still get those patients back from cath lab that are like, I'm just having a little bit of chest pain. It's always kind of one of those hard things, because they're going to have some pain with reperfusion depending on where it was and how severe it was. So you kind of have to just sort of really watch that and gauge it. If you're not comfortable and you're like, gosh, I'm just really concerned, call the doctor. Don't hesitate. Just call the doctor, get an EKG, and let them kind of go from there. So usually, like I said, if it's a full-on closure, you usually know pretty quickly. Arrhythmias, again, the reperfusion. If they're doing reperfusion, you're going to probably start seeing some extra ectopy going on, some increased PVCs. Just again, kind of keep an eye on them. A few are okay. If it looks like it's getting worse, then let the physician know. Contrast reaction. Usually contrast reaction for the most part is going to happen in cath lab, but it can happen within an hour or two after them coming back. And I have seen one of these on a patient in CCU once, and it was a really strange presentation, so it can happen. And then extremity ischemia, really important. We're just checking those, the pedal pulses. And then the pseudoaneurysm, and that's going to form down here. One of the ways you can check for this is you can put your stethoscope down there, and you can actually hear it if it happens. And so it's kind of a weird one because it's really hard to detect, but that is one way. If you listen down there, you'll actually hear like a brewery type thing. All right, so each one of these I'm going to walk through. So growing bleed, hematoma, retroperitoneal bleed. So all of those, all of those obviously are very very urgent things. And so if you have a growing bleed or hematoma, you're just going to get in there and you're going to hold that pressure. If it's arterial, you want to make sure that you are holding above the site because it's coming down this way. You got to hold that pressure. You don't want to hold right on the site. You want to be just slightly above that site so that you're holding above, okay? And then make sure that you're checking everywhere, getting down underneath, because sometimes those happen and they bleed down this way and you don't even realize because they're not bleeding outward. So when you are doing assessments, you got to get in their business and you just tell them, I'm going to be in your business a lot and just really be checking. And then sometimes the patient might complain of a stinging, and that's usually a sign that something's getting ready to blow. So if they say it's stinging, get down there because that's usually the only warning that you will get. So retroperitoneal bleeds, these ones are really scary because the patient will complain of back pain. Well, what does every patient on bed rest laying on their back complain of? Back pain. So these ones you really just have to watch their vital signs really closely because the hypotension is actually a late sign. So usually what you're going to see is their heart rate starts to climb up a little bit. And then you're going to get the hypotension. So if you have a patient complaining of back pain, really assess that back pain carefully. Do you normally have back pain? Does this feel like your normal back pain? Is this new back pain? Really assess that very carefully and then really look and see what their vitals are doing. Has their heart rate started to climb? Okay, because you're not going to see anything outward on this. What's happening is usually it comes from a stick, and it usually is a high stick, or a smaller people are actually more prone to this than heavier people are. And so it's kind of the risk is the female, the small body, the double stick, or the higher stick. And if they start getting hypotension, I mean, this is emergent. These people are running. You're running down the hallway to CT and getting them into CT and straight into surgery. And I've seen this several times on patients. And so call right away for help. It's such a hard one because that back pain is just really kind of one of those things. So other things you might see ordered, so you might get a CBC. Obviously, if you think they're having a retroperitoneal bleed, they're going to go straight to CT scan. But if you have someone that had a hematoma and it's big enough, they might decide they want to get a CBC on them. All right. And they may need a transfusion or surgery if it's a retroperitoneal bleed. Contrast reaction. Patient might complain of uncontrolled shivering or hives, tachycardic. It's kind of more of your typical allergic type of a reaction. Okay, so manage airway, histamine blockers, and notify the provider. Most patients, if they know that they have an allergy, they're going to be pre-treating them ahead of time. So, and then the pseudoaneurysm is leakage of the blood from the artery into the surrounding tissue that forms a hematoma, and you just don't really see it because it's not really outward, it's more inward, so you don't really even know what's happening. So, oh, that's probably Epic kicking me out. That was not Lauren. So you can listen for a bruit over the site, You may be able to see a pulsatile mass. I have never seen one of those, but I have heard of bruit before. And then the nerves adjacent to the expanding mass may need to lead to numbness and tingling. So as that aneurysm's expanding inside, it may start pressing on nerves, and so they might just start complaining of numbness and tingling. So anything, I really, with the femoral ones, I'm so glad we don't do them anymore, because they're really just, there's so many things with them, and they're all really hard things. I mean, if it outward bleeds, you've got it, but the other things are just so inward, it's sometimes just really hard to determine. So I always just say, there is anything different going on with them, get in there and assess them as best you can and notify the provider. There's just really check on them. So Doppler studies, and then thrombin injections, they can actually get in and just do an injection right in, and it basically, that is your vessel and your aneurysm starting to form. So you've got this little bubble, and they just do a thrombin injection that keeps it from expanding into it. So that's the best case scenario, or surgery. Chest pain, you're going to treat it per protocol. You're going to get your 12 lead. You're going to treat the patient, and you're going to notify the provider, and they're likely going right back to cath lab. So, and arrhythmias. So rhythm changes, again, secondary to that cardiac irritability, electrolyte imbalances. Maybe they came in and weren't really in the base, the best place to start with, or it could happen if they have closure of an artery. And so notify the provider. Like I said, you're going to see a little bit of it, but if you see something that starts to happen more frequently, you start seeing, runs of PVCs versus occasional PVCs here and there. Those are the ones that you want to be more concerned about. So the continual ooze, we're doing on time. The continual ooze, you've got the lido-epi, and those are pre-checked, and they usually are left on the order, so you can do that without notifying the provider. I always just say caution on this. Just make sure that you're looking at it, have somebody else looking at it with you, that it's an appropriate ooze that's capillary versus an actual leaking that's still going on. So, and what that does is has anyone ever done it before? So you've got your site, say this is your hole, and you just have this little ooze, and it just keeps coming out, and you're just like, oh, so you put a piece of gauze on it, and an hour later the gauze is kind of soaked, and what you end up doing is you just do little injections all around the site, and what it does is it causes vasoconstriction, so that capillary that's oozing, it just clamps it down and should stop it. It's like, yeah, it's not really a bleb because it's more of a straight in, and I can't remember the dose. I think it's like 0.1 mil. It says on the instructions, but don't quote me on it. I think it's like 0.1. I think. Yeah, and you just do little, like 5 or 6, just kind of around the site. So, and then it just constricts it down. So. Yep. And yeah, we're like, woo. I need no cardiologist to do that. Yeah, and we can look back at the orders too, and I can't remember what's in the instructions, but we can look at the orders when we're done again and see what the instructions tell you. But if you haven't done it before, find someone. Like, can we do this together? Pharmacy's really good too, because it's the same as kind of doing Regitine. If you've ever had to do Regitine for an infiltrate, it's the same type of process where you're just doing little all kind of around that site. So, except this is causing vasoconstriction, and it's usually opposite. Yeah, it does. It's the integral. Yeah, that's a good. Yep. So then your vagal reaction, and again, this is usually going to happen if you're having to hold pressure. So if you end up with a bleed, and so these patients, so if you end up with a patient that ends up with a hematoma, starts to bleed, and you have to get in there and hold pressure in their groin site, make sure you get those vitals going on them while you're holding pressure. Get those, that blood pressure circulating every couple of minutes so you can see what their blood pressure's doing. And then, that's why one of the reasons why we have monitors at the bedside for these patients, because if something happens, we need to be able to be watching what's going on with the patient while we're doing our interventions. So, and a lot of times the patients, because you're pushing so hard, they're like bearing down. And so trying to help them just sort of breathe through it. Relax. Atropine and fluids. And again, those are on your order. So start with relax, see if you can get them to kind of relax, breathe through it. But if they start to drop their pressure, you can do atropine. And call the doctor. So the one thing to make sure is it is critical to intervene, because if you think about it, they just had this fresh stent placed. They need that pressure to be pushing through that stent to keep it open. If they get hypotension, that stent can actually kind of collapse down, which will actually occlude the vessel back up. So, and there's your feet. Yeah, so pedal pulses, really important that we're checking those, and not just through that 6 hour, but that we're continuing that after our 6 hours is up, that we're really checking that. We had a patient once where a physician came in the morning and walked in the patient's room and pulled the covers back, and her foot was blue. Yeah, it was a bad situation. And it was a very young patient too. I think she was there. She'd had a PFO closure. So she was like 22 or something, and they were able to save it, but it was not good. She ended up going to surgery and having to, yeah. So always really important that we're looking, checking, touching, feeling. Okay, so comfort. Again, we talked about the back pain. You know, there's things you can do. You can put pillows underneath their knees. You know, they can be flat, but you can have pillows under their knees. It can kind of relieve some of that. But always be thinking in your back of your mind, is there something more going on? But so, again, try that reposition on them. You can, after the first hour, you can put the head of the bed up 30 degrees. You can shift them a little bit, you know, help them shift their hips around a little bit. You can kind of roll them a little bit. You can put a pillow under and kind of pull their backside up on one side. That's fine. The key is just keeping that leg as straight as you can. Back rubs. Give them back rubs. Comfort. Analgesics. And warm blankets are always really good. Pushing the fluids on them. These patients that are on bed rest that have had femorals, they don't really want to drink, but make sure that you're pushing the fluids. Those patients, you really just need to keep the IV fluids on. Usually the patients that are radial, they're more apt to get in there and drink, but people are, you know, on bed rest, they don't want to have to go to the bathroom. But it has to happen. Okay, let's go in and look at those orders, and then let's go through any questions you guys have. Let's look at that Lido Epi and see what instructions are on there. You guys have any questions while I'm getting to this?
The cubes, I know I messaged you and kind of talked about it. We kind of set on, like, after Cath lab, we want on the bedside monitor.
Oh, for how long? Yeah, you know, we don't really have anything in writing on that. Honestly, if you don't need the monitor somewhere else, I would just kind of leave it on them until you need it somewhere else. I mean, at minimum, they need to be on it for that 6 hour, that through that whole recovery vital sign. But I would keep them on it. If you don't need it somewhere else, I would leave it.
How many bedside monitors do we have?
Can someone answer that? Well, we had 8, but I think some were taken back.
I think
Yeah, we had some that I think weren't supposed to be ours or something. All right.
I know when they just did the update, we didn't plug it in. I know we have 6 right now. Because when I had to plug them in.
Is it in here? I can't remember where that was.
And ICU has a few, and they don't. ICU has a couple, and they don't actually like need them.
Yeah, so know that you can beg big burrow and steel if we have to. Okay, if someone sees that Lido epi, tell me, because they're saying yes. Mm-hmm. Yeah. Yeah. We don't see it a lot. We don't see it a lot, but we can do it. Yeah. Yeah. We don't see it a lot, but we can do it. It is. Yes, it's yellow. Lauren just printed this one off for you guys right now because I sent her the updated one. So yes, they are still yellow checklists. Okay, I'm having a hard time seeing it, but maybe it's under the femoral. Maybe that's why. There we are. Mm-mm. There's a standard on how all orders. It's just hey, I know. I know. There's no way to do it. It's well, I will tell you, if we put them as PRN, they will be missed. So that discussion's happened in the past, and they've been missed. So because they want the patients to have something to help get them relaxed. Because once they get over there, they've got to prep them and do all that stuff. So if we give them the Valium before they go, they're already starting to get into that relaxed phase while they get over there and get them all set up and prepped. Anxiety and yeah. Because usually by the time they get started and get going in there, they're probably a good 10-15 minutes while they're doing everything. So this way we've started that kind of relaxing on the way there. So when they call you. Yeah. As soon as they call you and say that they're coming, that's when I would give them. Yeah. Yeah. And that, and just make sure that your staff is aware to give them, because that happened, and not going to call anyone out, but not knowing on call to cath lab what that really means. Some people think, oh, that means they give it when they get on call in cath lab. But that actually means we're going to give it when they call us. So just, that's a good thing to follow up when you have staff that are going, just because we saw it happen. So that's how we learned, like, oh, okay, yeah, I hadn't thought about that. So yeah, it's all an interpretation. So.
It's different than pre-op. It's different than pre-op.
Right, I was talking to Amanda. She's like, that's not.
Well, and that's right, and that's what's confusing about it, is that we only have one pre-op phase of care, which covers right before they go, and while they're there. So it's I know it's a challenge. So it doesn't have any. I thought it had more instructions, but I think when pharmacy sends it to you, I'm pretty sure they have instructions. But if they don't, again, you can reach out to them. It just has the 4 mils, and then it doesn't give any more instructions, so I would have to look it up. Do they? Yeah. I mean, you want someone that's done it before that can kind of guide you and walk you through it. But yeah, it doesn't have to be the charge nurse that does it. So, and if nobody's done it, then you call pharmacy and you just kind of work through it. Honestly, I mean, you look it up and call, and yeah, exactly. Yeah. Oh, they're out. They're done. That's right. Yeah. Yeah. And most cath lab is an hour and a half would be kind of long, but if they're doing an intervention that might be a little difficult, it might be an hour and a half, but they're usually pretty quick in and out of there. So
You guys may have already talked about it. Are you planning to do these at night, or are they still supposed to be?
And the night would just be an emergent case, and I would imagine that's probably not going to happen for a while. So
Right now we're recovering
right. Yeah. Any other questions, thoughts?
I think Rachel, if she can hear, I don't know, but we actually had to, just kind of a side note, Cath did come back and they didn't go through their checklist, and Rachel had to bring it up to them.
Good.
Like, oh, I didn't think we had to go through this. she did make them. So just a call
Good
out
job,
for that,
Rachel.
that, you might need to prompt them.
Yes, yes, right, and so I think what we'll do is I think we'll follow back up with Dennis because Dennis knew we were doing this and we were hoping he could come, but since it's totally off their time, they didn't want to have overtime and stuff. So we'll just follow back up with Dennis and say, hey, we got everybody level set. We'll just kind of walk through with him again. They know the expectations. We know the expectations, so nobody's pretending they don't know what they're supposed to do. Because they are nice, but it has been a challenge. I really would like to get, so they have the report, they have the post report that they could actually print and start using. So again, I'm kind of working through some things. So we may get to the point where we're still having to use the checklist pre, but post, if they could come back, if they could come back with this section E on a printed piece of paper, it would be super. And they have it. I just don't think that they've used it here because right now it's only been used in Boise. And it's really nice. So anyway, so we're talking about that because it saves it for them. Because what happens is all this stuff on here, it pulls in from their log into a report, and they just click report, and it prints, and it has it all there, and it's super nice. So.
We were just talking about that.
I don't.
I'll circle back with Kayla and see what we were thinking. I mean, it wasn't meant to be forever, you know.
Yeah, it wasn't meant to be forever. Yeah. We keep sending everybody for open heart. Oh.
And this conversation actually came up last. It really was this about that last night, and that's why.
And what?
We need to hurry this.
Yeah. No. Well, and I think so. What we want to do is circle back with Kayla and find out who we need to connect with cardiology, because I think we just need to connect back with them and say, okay, we've got everybody level set. We've went through all the training again. Marilyn's working with them. I mean, Jen's been reaching out to me every time a patient comes through, and I get in and I've been looking at charting, and just because if we can do that one-on-one right away and get us all going, we'll be fine. So we'll know.
There was a conversation last week where you guys were out of the ED. So I did talk to Kayla, like, in the event that tonight, I think Julie was on, so she's like, as long as there's a nurse that knows how to care and they're very good numbers,
Yeah.
we're gonna potentially have to.
Yeah.
And then resource you guys.
Did you?
Yeah,
Well,
that's about leaving them over there and leaving one of us really sort of in charge of that telemarketing. Yeah, it was like everybody's got a COVID last night.
Yeah.
We're like, right, what do we do when we have somebody come in?
This conversation that I talked Sunday, we had this exact conversation about getting cath lab patients in. So the nurses that I was with, that we were ready, okay, they're ready, they want to do it.
We're ready.
As a cardiologist point, like if we field questions through ICU.
Well, that's why we need to figure out who to circle back with in cardiology and have that conversation, because I found out about it after the fact, and honestly, had I known before, I would have tried to get in there and
we
work with them.
Telecharges, come to this class so that you can be a resource. We didn't get all of the tele nurses into this class because we really wanted to focus on your guys' expertise. So when we do have those cath lab patients, that you'll be double checking that charting.
Yeah.
So, talking to the nurses, ensuring that they really have dotted all their I's and crossed their T's.
Yeah, really watching them closely. And like Jen's been doing, if you get a patient and you guys want to send me an IM, hey, I got a patient in such and such room, I will get in real time and try to look through charting with you too to make sure that you guys are getting the charting where it should be. And
It's like
where to document it.
Yeah, it's in the vital signs.
Yes. Yes. Yeah. Well, you mean to ICU? Well, until we can get the physicians to agree, we just have to do what we're doing right now. So.
Between a non-intervention care for non-intervention
and an intervention. The only difference is your intervention patients are going to have heparin on board, so their risk of bleeding is going to be higher. That's really the only difference. So, yeah, and the complications related to placing a stent. Yeah. So, okay.
Anything else, guys?
So,
Why don't they use nitro patches above the tear here?
I have never heard of that.
We use it down in the attic to prevent vasospasm.
We don't have a problem with vasospasms. I know when we first started, no, you know what? That Crystal is a good question, because when we first started Radial, that was the big concern, was vasospasms, and we actually had one physician in his training had a patient vasospasm and he couldn't get the sheath out, and he's like, I'm not doing this anymore. He was like, done. But that's the only time we've ever had a problem with vasospasm. So it might have been an early on practice, quite honestly, when they first started doing radials, and it's probably not a standard anymore. So would be my guess. Yeah.
And then I was from ICU last week, and they said like they've called, we've said like people go over to the ICU.
Oh, yeah.
Crystal said the process is pretty much the same, but when they have like something weird going on,
Yeah.
they go over to the charge.
Hey, you want to come over and go through it with us?
And then also Dennis mentioned to ICU that like 90% of those see the Cath lab.
Oh, do we have them stops here just in case?
We have fem stops, but if you need a fem stop, a physician has to be called, place the order, and has to actually place it.
Oh, yeah.
Yes.
Yeah.
Yeah. It's yeah. And gosh, I haven't seen a fem stop placed in a long time, so we've been able to not use them. So, but we do have one. Jen and I made sure. We made sure we had it on the floor. Yeah. Yeah.
Like almost 1-to-1 care.
Yeah. Okay. Thanks, you guys. Like I said, questions, comments, thoughts, just send them to me. Thanks, Rachel.
Thank you.